How to manage upper GI disorders? How do you care for patient with a type 2 rolling hernias versus a type 1 sliding hernia? What is the rising link between HPV and oropharyngeal cancer? What is the critical nursing intervention for esophageal trauma? In this chapter 56, coordinating care for patients with oral and esophageal disorders, the learning outcomes are for correlating clinical manifestation to pathophysiological process. We have complication associated with diagnostic result used to confirm the diagnosis, and treatment and nursing management for stomatitis, the hernia, the GERD, oral cancer or oral trauma, esophageal cancer, and the trauma. Research chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I always like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters. This is my concept map that I always talk about. So this chapter 56, coordinating care for patients with oral and esophageal disorders. Every chapter has the little introduction. Then we have stomatitis, hernia, GERD, oral cancer, oral trauma, esophageal cancer, esophageal trauma. Each of these disorders has the epidemiology, pathophysiology, and interprofessional management. So see you next into the introduction. Introduction for oral and esophageal disorders. So introduction, we have the anatomy of upper GI tract. It's the oral cavity. Extend from the lips to the anterior tonsils. The function is to chewing, the mastication, taste, breathing, and speech articulation. The esophagus, it says that it's 25 centimeters long, 2 centimeters in diameter, muscular canal. The function is to transport food from the pharynx to the stomach. Vulnerability and prevention. Both of the oral cavity and esophagus are susceptible to injury, infection, trauma, and cancer. In healthy people, 2030, because this year we are in 2025. So in healthy people, 2030 guidelines emphasize prevention through the elimination of risk factors like tobacco use, physical inactivity, obesity, and UV exposure. Screening key for preventing oral cavity diseases often occurs for esophageal disorder only after the disease has progressed and symptoms appear. Health disparities. The National Center Institute highlights the impact of health disparities and social determinants on cancer risk. Socioeconomic status is the most prevalent factor influencing access to education, health insurance, and safe work environments more than race or ethnicity. Also affects the behavior risk factors like smoking, physical activity, obesity, and participation in cancer screening. Stomatitis, epidemiology and risk factors, inflammation of the oral mucosa, dentition, and periosteum. So about 40% of chemotherapy patient will occur in those patients. About 90% of head neck radiation patients will develop high severity in females. Risk factor it's viral, fungal infections like candida, radiation, chemo, nutritional deficiencies like vitamin B, 12, zinc, iron, irritants, tobacco, alcohol, mouthwash. The pathophysiology is the inflammation and ulceration of the oral mucosa, often involving like lips, tongue, and buccal mucosa. Primary, we have the aphollosis ulcers, the cracker sores, the herpes simplex, traumatic ulcers. Secondary, it's infection caused by the viral, bacterial, or fungal in immunocompromised patient, example chemotherapy, radiation. In intervention is saliva substitutes, frequent mouth care. For clinical manifestation, it's dry, red, swollen, cracked oral mucosa, mouth ulcers, open, bleeding, sores, and pain. Dysphagia, difficulty of swallowing, or odynophagia, painful swallowing, and the dry mouth xerostomia. In key term, I show up some pictures there, how to remember those key terms. So humidification and frequent rinsing with saline or sodium bicarbonate, the baking soda. The diagnostic is physical exam and patient history, chemo, radiation, exposure, grading scales used to rate the severity of symptoms, for example, grade 1 to grade 5. Treatment, analgesics, antifungals, nystatin for thrush, dental cleaning 1 month prior to cancer treatment. For nursing management, we have assessment, which we monitor vital signs, temperature for infection, nutritional intake, weight, and fluid intake. Make sure it's the patient it's hydrated or not. Action, we have implement aspiration precautions, suction at the bedside, the head of bed elevated to 45 degrees, administer antimicrobial like tetracycline, minocycline, antiviral like acyclovir or antifungals nystatin, or as prescribed. Administer viscose lidocaine or other analgesic for pain. Intervention here keep it always ABC to make sure it's aspiration precaution. The meds available. Patient teaching. We need to have a proper mouth hygiene, or we use a soft toothbrush and frequent mouth care with warm saline or baking soda. So avoid the alcohol mouthwash. Um, Remove denture if pain is severe. Eat foods high in protein, vitamin C. Avoid spicy, salty, acidic, or hard foods. The outcome is pain control, stable weight, and adequate hydration. If you take a short screen of this, this is like your concept map for stomatitis. And this will give you like a quick insight, an overview, quick insight to your school studies, but for more deep in, better read the chapter and especially the section. So as I said, this is different type of concept map. Earlier is like a flashcard. This is like image wise. I like this as well. You see here facts like stomatitis occurs in about 40% of patients receiving chemotherapy. The rate and the severity are higher in females rather than males. Up to 90% of patients receiving chemoradiation for head and neck cancer will develop stomatitis. It is a preventable disease process except when related to radiation and chemotherapy. We have here the pathophysiology. Stomatitis or oral mucositis is an inflammatory condition affecting the oral mucosa, dentition, and the periosteum. It presents as painful inflammation and ulceration, um, ulceration of the lining of the mouth, which may include the lips, pharynx, tongue, gingiva, and other mucous membrane. We have the primary stomatitis, which includes the cracker sores, herpes simplex, stomatitis, and traumatic ulcers. We have the secondary stomatitis, which result in viral, bacterial, or fungal infection in patients with suppressed immune system, often due to chemotherapy or radiation. Mechanism of chemotherapy destroy mucous membrane cells faster than new ones, then can develop or leading to painful sores. The risk factors, it's viral, bacterial or fungal, candida, irritants such as alcohol, tobacco, and mouthwash, radiation therapy 7 to 14 days after start, and chemotherapy peaks like between 6 and 12 days after the last dose. Allergies to metal, medication, dental material, cosmetics, gum, or foods, vitamin deficiencies like vitamin B complex, folate, zinc, iron. Poor oral hygiene and ill-fitting denture, systematic diseases like chronic kidney disease and inflammatory bowel disease, xerostomia, the dry mouth, and then we have here nice signs and symptoms. Slide with dry, red, swollen, and cracked oral mucosa, mouth ulcers, including recurrent cracker sores, open bleeding, mouth sores, pain, which can lead to dysphagia or painful swallowing. Presence of candidiasis, the trash, appearing as redness, cracking at the corners of the mouth, or white coating on the tongue. The xerostomia, decreased fecal or no saliva. In diagnostics, the physical examination, assessment of the oral cavity for inflammation, ulceration, and lesion. Patient history, evaluating exposure to chemotherapy, radiation, steroids, or history of decreased immune function. Clinical presentation based on physical findings and patient reports of pain or difficulty swallowing. Grading scale used to rate the severity symptoms, grade 1 to 5. We have patient teaching, oral hygiene, perform oral mouth care after each meal, and as needed using a soft toothbrush. To rinse, use frequent mouth wash like every 4 hours with warm saline or sodium bicarbonate, the baking soda. This solution can clean and comfort the mouth. Avoid irritant. Discourage the use of alcohol-containing mouthwash and lemon glycerin swab as they dry and irritate tissue. The denture, remove denture if or oral appliances if experiencing severe stomatitis or oral pain. Clean them daily. Diet, avoid spicy, salty, hot, hard, acidic foods or food with sharp edges. Choose food high in protein or vitamin C to promote healing. For denture care, encourage regular dental checkup at least 1 month before chemo. We have radiation, hydration, sip water and suck on ice chips to manage the dry mouth. So that's it for stomatitis. Hiatal hernia. We have the stomach pushes up through the diaphragm into the chest. Around the 50s is the prevalence increases. Here is the type 1 and type 2. I said like how do you care for patients with type 1 and type 2. We have the signs and symptoms for type 1, for type 2. Medical management and diagnostics. We have here the diagnostic, the ballroom solo with fluoroscopy, more specific, EKG and CT scan, the surgery, and my key terms in the slides with picture. I post about these. I have a nice picture over there about that. And so since we still are in clinical manifestation for type 1 heartburn, regurgitation, chest pain, dysphagia, blanching. For type 2, feeling full, breathless after eating, feeling of suffocation, chest pain, angia-like symptoms worsen when laying flat. Nursing management action, administer antacids, H2 blockers, or PPI, position patient supine on the right side with head of bed elevated to 30 degrees after meal to promote gastric emptying. Teaching, limit spicy, fatty foods, coffee, chocolate, carbonated drinks, peppermint, acidic foods, and alcohol. Eat meals 2 hours before lying down. Wear non-restrictive clothing. Complication, the volvulus, the stomach twisting. It's an emergency. Iron deficiency from slow bleeding. Post-operate, the gas bloat syndrome. Avoid drinking with straw. Carbonization. Now this is like the quick flashcard. Now let's go to the next slide where I have pictures as I did before. Here you see we have the facts, the prevalence, the incidence increases with age with about 55% to 60% of those affected being 50 or older. Type 1, so the 95% are type 1, the sliding hernias, while the 5% are type 2, the rolling. So it's paraesophageal hernia. Association with GERD, 96% of patients with Barrett esophagus have a hiatal hernia, is 2 centimeters or larger. The demographic, it is more common in Western countries due to lower dietary fiber intake and sitting position using used for defecation, which causes straining. The pathophysiology definition in the book, it says that hiatal hernia occurs when the part of the stomach protrudes upward through the esophageal hiatus, opening in the diaphragm into the thoracic cavity. The type 2, the sliding, the most common type, the hiatal tunnel winds, allowing the esophageal junction and part of the stomach to slide up into the chest. This often leads to reflux as stomach acids contact esophageal tissue. In the part 1, the key terms, I have those definition and pictures. The type 2, the rolling, the paraesophageal anatomical defect prevents the stomach from anchoring correctly below the diaphragm. This stays in place, but the fundus, the top of the stomach rolls up through the hiatus alongside the esophagus. This type can become strangulated or incarcerated, which is a surgical emergency. Risk factors, it's obesity, approximately 20 to 53% of morbidity. Obese patients are at risk. Age, supportive structure weaken over time. Pregnancy increases intra-abdominal pressure, lifestyle, smoking and straining during defecation due to low fiber diet. Physical strain, repeated deep inspiration, Valsalva maneuvers, and heavy lifting. Signs and symptoms for type 1, the sliding, often asymptomatic. If symptoms occur, they include heartburn, regurgitation, chest pain, dysphagia, and bleaching. For type 2, the rolling, feeling full or breathless after eating, feeling of suffocation, chest pain like angia, and worse symptoms when lying flat. Um, General complications, iron deficiency anemia from slow bleeding, Cameron lesion, so it's erosion, ulcers, and respiratory symptoms if aspiration occurs. The diagnostic is the barium solo with fluoroscopy, the most specific test for diagnostic. We have the EGD, the esophagastroduodenoscopy. This views the lining of the esophagus and stomach. Others, the upper abdominal X-ray, endoscopy, and CT scan. Patients teaching dietary changes first, limit spicy, fatty foods, caffeine, chocolate, carbonated drinks, acidic foods, peppermint, and alcohol, as those decreases low esophageal sphincter pressure. Eat small, frequent meals rather than large ones. Avoid eating 2 hours before laying down to prevent reflux. The lifestyle modifications: wear non-restrictive clothing to avoid increasing intra-abdominal pressure, maintain a normal weight, elevate the head of bed at 30 degrees after meals to use gravity to keep acid down, avoid straining or heavy lifting. Post-surgical care after the Nissen fundoplication. Follow a soft diet for about 1 week. Take small bites and eat slowly. Avoid activities that can cause air swallowing, drinking through straw, chewing gum, carbonated beverages to prevent gas bloat. Report severe bloating, inability to vomit, burp, or difficulty swallowing immediately. So repeat those, teach the patient to report severe bloating, inability to vomit or burp, or difficulty swallowing, like immediately. That's it for hernia. We go next to GERD. GERD, we have about the book says that GERD is a chronic condition characterized by acid reflux from the stomach into the esophagus, causing various clinical symptoms with or without tissue damage. Uh, it occurs when the lower esophageal sphincter is weak or relaxes inappropriately, leading, I had to cough, leading to a loss of the pressure gradient that normally prevents stomach contents from entering the esophagus. Contributing factors: weak LES, living lifestyle choices, certain foods and substances that affect. Also, hernia is associated with GERD, but not always. Pathophysiological protection: the esophagus has natural defenses against reflux, including gravity, peristalsis, and bicarbonate-rich saliva. The epidemiology: high in Western countries is like 10 to 25%, low in Asia countries is about 5%. Possibly due to lifestyle, diet, and the prevalence of H. pylori, the Helicobacter pylori. This is a gram-negative bacterium that can decrease gastric acid secretion, but is known carcinogen, and its eradication is a public health goal. Um, the factors for decreasing LES pressure, it's the hernia, the hypotension, loss of esophageal mobility, obesity, pregnancy, ACT, ascites and tight clothing, eating large meals and delayed gastric emptying, tobacco use, and certain medication. Let's see the diagnostic. The initial diagnostic, it's based on classic symptoms and the positive response to a trial of proton pump inhibitors, the PPIs. 24 hours ambulatory esophageal pH monitoring. This is the most useful test for typical symptoms. The esophagogastroduodenum evaluates esophagitis, allows for biopsies, and can dilate strictures. The esophageal manometry, the gold standard for assessing esophageal monitor activity. The cardiac workup required to rule out cardiac causes of chest pain. Medications: anti-acid, so this neutralize stomach acid. Histamine receptor antagonist decrease acid production, is a short acting. The prokinetic medication increase gastric emptying, like metoclopramide. The PPEs, the proton pump inhibitors, reduce acid production, long acting, but long-term use is associated with side effects like fracture. So see table 56.4 for more details. Endoscopic and surgical management. We have the endoscopic treatments, the stretta procedures, uses radio frequency energy to reduce pain by decreasing vagus nerve activity, and endoluminal gastroamplification titles the LES with sutures, magnetic sphincter augmentation, implants magnetic baits to prevent reflux. Surgical management, the gold standard is laparoscopic Nissen fundoplication, which is reserved for patients who do not respond to medical treatment or who have complication. Complication, very important. Barrett esophagus, precancerous condition where the normal squamous cells of the esophagus are replaced by columnar cells, which have a high risk of malignancy. The strictures, fibrous and scarring from chronic acid exposure can lead to esophageal narrowing and dysphagia. For nursing intervention, it's just slide the the slide all over. So administer the anti-acid histamine receptor antagonist and teaching. But here, this is the slide with nice pictures that it's a little bit different than the above. So we have here the prevalence is highly prevalent in Western countries. We said GERD is a chronic disorders where the acid reflux of the stomach flows back into the esophagus, causing clinical manifestation with or without tissue damage. The lifestyle linked to choices are the primary determinants of getting GERD. It's usually occurs association with hernia. GERD results from retrograde flow of GI content into the esophagus, leading to inflammation. And here we have a nice picture of pathophysiology. You see here the LES, I like pictures. So the most common cause is the relaxation of the lower esophageal sphincter. So this one here, LES, the lower esophageal sphincter, which allows gastric reflux into the esophagus. The issue when the esophagus is inflamed or injured, its ability to clear reflux material slow down, extending the exposure to acid. Each episode of reflux damages in hyperemia, increased blood flow, erosion, and possible minor bleeding in the esophagus. The risk factors: eating large meals, delay gastric emptying, obesity, tobacco use, alcohol use. The anatomical, physiological, the hernia, the lower esophageal sphincter, hypotension, loss of esophageal mobility, increased gastric secretion, and pregnancy. The external factors, it's as CT is tight belt or girdle and presence of a nasogastric tube. Signs and symptoms common: heartburn, dysphagia, severe typical chest pain, regurgitation, and belching. Respiratory, where chronic cough, morning hoarseness, adult onset asthma, laryngitis, pharyngitis, and bronchitis. Now, when I'm in these chapters that I record and I read, my throat hurts and and thinking like, what I should have. What all this I have? Um, it's just talking, and not breathing while I'm talking. Then my throat gets irritated and makes me to cough. But back to our GERD complications. It's odynophagia, painful swallowing, hemorrhage, dental caries, the cavities, aspiration, pneumonia, and water brush, excessive saliva. Malignancy concern, weight loss, dysphagia, hematemesis, and melanoma, black tarry stools. The initial diagnostics, often based on um, reported symptoms and a trial of PPIs. pH monitoring, so it's like 24 hours ambulatory esophageal pH monitoring is useful for patients with atypical symptoms. For endoscopy, evaluates esophagitis, monitors for Barrett's esophagus, and allow for biopsy. Esophageal manometry is the gold standard for assessing esophageal motor activity through use infrequently for diagnostic GERD itself. Patient teaching, we have the dietary avoidance, limit spicy fatty foods, caffeine, chocolate, carbonated beverages, acidic foods, peppermint, and alcohol, as those decrease the lower esophageal sphincter pressure. Meal habits, eat 4 to 6 meals per day instead of 3 large ones to decrease stomach pressure. Avoid eating late at night and wait 2 hours after meals before laying down. We have more, make sure that the patient elevate the head of bed 30 degrees, right? Make sure that positioning, sleep on the right side with the head of bed elevated. It's about 6 to 12 inches to promote gastric emptying and prevent reflux. The lifestyle, again, avoid smoking and alcohol, maintain an ideal body weight, and wear non-restrictive clothing to prevent increased intra-abdominal pressure. Take the meds, avoid NSAIDs and aspirin if possible, as they can irritate the esophagus. So once again, the GERD, the pathophysiologist, the chronic backflow of gastric contents into the esophagus due to a weak or relaxing lower esophageal sphincter. Causes inflammation, erosion, and can lead to Barrett esophagus, precancerous. So keep in mind this because the heartburn and severe atypical chest pain, odynophagia, hemorrhage, dental caries, chronic cough, morning hoarseness. So these are very important in the quizzes and for the NCLEX and patient bedside care. I call this the honorable mention of oral cancer. We are in oral cancer section. While the survival rates can be higher, especially if HPV positive, the treatment can be frightening due to potential disfigurement. Surgery, extensive surgeries can include gastrectomy, removal of a part or all of the tongue, mandibular lectomy, removal of a jaw bone or neck dissection, removal of lymph nodes, muscle veins, and nerves in the neck. Impact those procedure can permanently affect your ability to speak, eat, and breathe, as well as alter your facial appearance. We go to more detail. We have epidemiology and risk factors. The oral cancer constitutes 3% of all cancer causes in the United States, with an estimated 54,000 new cases and 11,230 deaths in 2022. It is more common in men, 2 to 4 times more, and the risk increases with age, with the average age of diagnostics being 62. The oral cancer accounts for 25% of all head and neck cancers. Survivor patients who survive 5 to 10 years have 20 times higher risk of developing a second cancer. The HPV, the Human Papillomavirus, the incidence of oropharyngeal cancer is rising, with up to 71% of new cases linked to HPV, especially HPV 16. Those patients tend to have a much better prognosis than those with HPV negative cancer. The lip cancer causes intense sun exposure, excessive alcohol consumption, and smoking. We have the types: squamous cell carcinomas. About 95% of lip carcinomas, 85% occurs on the lower lip. The basal cell carcinomas, less common but tend to grow slowly and are invasive over time. Pathophysiology: we have primary type. The majority of oral malignancies are the squamous cell carcinomas, which arises from the squamous epithelium lining the oral cavity. It's around 90% and linked to nicotine and alcohol use, and approximately 75 develop in the gutter area of the mouth, the area between the lower jaw and the tongue. This location is significant because it is a drainage area where the irritants collect, and the tumors in the region have a higher propensity for metastasis. Other type is the basal cell carcinoma, the second most frequent oral cancer, atypical, appearing on the lips. It rarely metastasis but can be locally invasive. We have also the verrucosus carcinoma, a low grade that rarely metastasis. A pre-malignant lesion, the leukoplakia is said in key terms. It's the white, the most common pre-malignant lesion appear as non-removable white plaques due to chronic irritants. It is most common in adults over 40 and has the potential for malignant degeneration. The erythroplakia, the red one, less common but highly suspicious for malignancy. Those are macular red velvety lesions that require biopsy. Here we have the clinical signs. We have the early onset, it's asymptomatic. Late stage we have oral bleeding, non-healing ulcers, white and red, etc. The lab test, it's a CBC, chemistry profile, liver function test, imaging, ultrasound, CT, PT scan, MRI to evaluate tumor size, location, and metastasis. Chest X-ray to rule out metastasis to the lungs, panorex films. It's the X-ray of the mandible to check for bone invasion. The HPV status, patients are tested for HPV status, medical management, treatment options. Treatment depends on the cancer size, location, and stage. It includes combination of surgery, radiation, and chemotherapy. We have radiation therapy, external beam radiation, which is used to destroy cancer cell. Then we have the intrastitial implantation, the brachytherapy. It's a radioactive seeds are placed directly into or near the tumor. The chemotherapy can be used alone, like neoadjuvant, or after adjuvant surgery, radiation. Target therapy, we have meds. For that, the surgical management for small lesion can be removed using a scalpel, laser, cryotherapy, and photodynamic therapy. Large tumor may require extensive surgery like glostectomy, removal of part of all or all of the tongue, partial mandibulectomy, jawbone removal or neck distinction, removal of lymph nodes. Nursing management, airway management, So keep emergency equipment at the bedside. Aspiration precaution, assess swallowing, provide efficient liquids, and elevate the head of bed at least 30 degrees. Oral care, provide frequent oral care to manage xerostomia, dry mouth, and reduce infection risk. Administer steroids to decrease oral edema, and medication to manage pain and other symptoms. Consult a nutritionist to ensure adequate caloric intake. Educate patient for aspiration precaution and importance to avoid tobacco and alcohol. Provide education for high protein foods and use uh, sauces and seasoning to improve taste. Also, teach patients or family how to perform daily oral cavity assessment and manage the dry mouth. To evaluate the outcome, the patient education focus on lifestyle changes, dietary modification, advanced disease for stages, care focus on managing the side effects of surgery, radiation, and chemotherapy. Now let's go to our beautiful slide that has nice picture on it. Here are the facts. The pathophysiology, risk factors, signs and symptom diagnostic, and patient teaching for oral cancer. Oral cancer, I said, accounts for 3% for all new cancers. 54,000 new cases in 2025. So we have for viral, like here, for viral, infection for herpes simplex and the human papillomavirus, the 2, 11, and 16. The irritants, the genetic mutations. Keep in mind the signs and symptoms. Early signs, patients are often asymptomatic. Lesion, oral ulcers with poorly defined margins. Mucosal lesion, nodules, or white red patches. I think the most I like here, this picture is pathophysiology. I think this is really nice. Where we have the cell type, the majority of oral malignancy are the squamous cell carcinoma, which arising from the squamous epithelium that lines the oral cavity. We talked earlier about diagnostics, the imaging, the CT scans, MRI, PET scan, chest X-ray, lab, CBCs, liver, the patient teaching what to avoid, airway and swallowing, oral hygiene, how important it's oral hygiene, nutrition, encourage on high protein, and this can be in the quizzes or NCLEX because it's nutrition. So how the patient will need to increase the diet, um, the high protein diet. Um, and the use of sauce or gravies to make food more palatable if taste changes occur due to the chemotherapy. So this can be in the selector or the apply, the sauces, gravies. Management for the dry mouth, frequent sips of water, saliva substituents, um, and that's it for oral cancer. Oral trauma. The epidemiology is the injury to facial bones, um, nasal, mandibular, maxillary, and soft tissue. Causes: car accidents, sports, physical altercation, falls are the main cause in adults. Falls are the main cause in older adults. The pathophysiology, the number one priority is the airway occlusion due to bleeding, swallowing, high bleeding risk. The face is highly vascular, infection risk, high due to oral flora. Leofond fractures, classification system for maxillary fracture 1, 3, 2, 3. Signs: respiratory stridor, short of breath, low oxygen saturation, hypercarbia, general oral bleeding, swallowing, pain, lost teeth, tachycardia. For management, airway, control for bleeding, suctioning, check for dislodged teeth, may need emergency tract, Bohr's rectum antibiotic. Diagnostics, we have the facial X-ray, CT scan, MRI labs, CBC, ABG type, and cross-surgical. We have the plates, screws for stabilization, fixed occlusion, the jaw wiring, the wire shut for 6 to 12 weeks. We have a safety alert here. The wire cutters must be at the bedside at all times to cut wires in case airway emergency like vomiting, choking. Nursing management, monitor for airway, stridor, bleeding, edema, look for CBC, labs for infection and blood loss. Intervention, right? Keep the wire cutters with the patient, use oral humidification, head of bed 30 to 45, for diet, tube feeding, for liquid soft diet via straw syringe. Frequent oral care to prevent infection, teaching, make sure that teach family how to use the wire cutters and to notify provider immediately. Infection, report fever, pain, or purulent drainage. So the outcome is to have a stable weight, no infection, and healed wounds. Now let's go to our nice picture. Sorry guys, I just noticed that it's more than 1 hour. This chapter is very dense and quite long. The oral trauma encompasses injuries into a specific facial bones, you see here. Nasal, mandibular, maxillary, and soft tissue, and around the mouth. The causes we know include the automobile accident, physical altercation, and athletic activities like boxing or basketball. Age factor, of course, over 60-year-old, primarily due to falls. Fracture types, we have maxillary cellular fracture are classified as low found 1, 2, and 3 based the lines through the alveolar ridge, nasal bones, and sigmomatic arch. Pathophysiology, we know the airway compromises. That is a primary concern due to damage to the oral cavity, leading to partial or complete airway occlusion. Hemorrhage, the face has a rich blood supply, creating a risk factor for significant blood loss and hemorrhage that can further obstruct the airway. Infection risk, trauma can induce infection due to the presence of normal flora in the mouth. Risk factor, we have participation in the contact sports, basketball, baseball, boxing, operating motor vehicle, so risk for accidents, advanced age because of risk of falls, physical altercation. Signs and symptoms, for respiratory have the stridor, the noisy breathing, short of breath, increase of respiratory rate, decrease oxygen saturation, and hypercarbia. Physical, oral bleeding, swallowing, edema, loss of teeth, and pain. Systemic, elevated heart rate and changes in level of consciousness. The diagnostics, facial X-ray, CT or MRI to evaluate bone and soft tissue damage, labs, CBC. We have the serum chemistry analysis, arterial blood gas, ABG, and blood typing cross-matching for potential transfusion. For patient teaching, the wire clavers at the bedside. To be with the patient at all times, to cut the wire in case of respiratory distress. They must notify the healthcare provider immediately if wires are cut. Oral hygiene, perform mouth care after each meal to decrease the risk of inflammation or infection. Lastly, we have infection monitoring, report signs of infection such as fever, increased oral swallowing, pain, or change in oral secretion. So that's it for our oral trauma. So esophageal cancer stands, it's stronger counter due to its high mortality rate and violent causes. Why those two are particular frightening based on this text? The esophageal cancer, it's the silent killer. Later we're going to talk about esophageal trauma, that it's also very high in mortality because we are in esophageal. But let's talk about the esophageal cancer, the silent killer. The condition is terrifying because it is often advanced by the time it is found, and the chances of survival are low. Poor survival rate, the text states that the overall 5-year survival rates range from 10 to 20. Late detection, patients are usually asymptomatic until the tumor has occurred 50% of the esophageal lumen and metastasis has occurred. This means you might not know you have it until it has already spread to your lungs, liver, or bones. Severe treatment surgery often involves an esophagectomy, where a large part of the esophagus is removed and the stomach is pulled out into the chest or neck to replace it. Now we go into our concept map. So the esophageal cancer, starting in the mucosal layer of the esophagus. Types: squamous cell carcinoma, adenocarcinoma. The high mobility is 5 years, survival is low, 10 to 20 rate, too late detection. So the risk factor: alcohol, tobacco, age 45 to 70, usually male, the medical, the Barrett esophagus, chronic GERD. The pathophysiology: it's the tumor grow rapidly and spread to lymph nodes, liver, and lungs. For clinical, we have dysphagia, painful swallowing, and other, like coughing blood, hoarseness, melemma, which is black stools, weight loss, hypercalcemia. The diagnostic, we have the EGD. It's a gold standard. Visualize and biopsy the barium, solo, the CT, PET scan, surgery, the esophagectomy, endoscopic complication. It's the dumping syndrome. Here I'm gonna make some notes about the dumping syndrome. Dysphagia, stomatitis from radiation, nerve damage. The nurse assess the respiratory, GI, and calcium. To intervene, make sure the head of bed is elevated. Diets of foods, thickened liquids. Post-operation, it's 6 meals a day, just to prevent the dumping syndrome. Teach the pre-op, stop smoking, cough, deep breath, incentive spirometer to prevent pneumonia. Dumping syndrome, teach diet changes, small meals, no fluids. I have a slide about dumping syndrome. The outcome: primary goal, maintain weight and nutrition and quality of life. Palliative focus is common due to late diagnostics. So now we go to our beautiful picture. Here it's you see here it's like 1% of all new cancer causes in the United States, with significantly higher incidence in men than women. So it was a report that 13,480 versus 3,810 estimated cases in 2018. Well, it's been a while ago because now we are in 2025. Survival, it's the 5-year survival rate are low, ranging from 10 to 20%, largely because patients are usually asymptomatic. Only the tumor occults 50% of the esophageal lumen, and metastasis has occurred. Types: we have 2 types. One is the squamous cell carcinoma, and the other one is the adenocarcinoma. The first one, this one, it's more common in Asian population and associated with alcohol, tobacco use. This one, it's more common in Western population and people of European descent. Incidence in rising due to the prevalence of cancer. So I'm European, so I have to keep this in mind. For pathophysiology, the location of this one, the pathophysiology of this one, usually affects the upper 2/3 of the esophagus. See here. For this one, the pathophysiology is mostly found in the lower 1/3 of the esophagus, often at the gastroesophageal junction, right here. The mechanism, you can read more in the book. The progression, the tumor grows rapidly, involving the esophageal lumen and neighboring tissue, and often metastasizes of the liver, lung, bone, and stomach. We have risk factor, alcohol and tobacco. It's risk 18 times for those drinking. The diet low in vegetable and fluids, and obesity associated with hernia and GERD. Medical condition like GERD and Barrett esophagus. Other condition is like strictures, esophageal diverticula, tylosis, achalasia. The demographic, it's 45 to 70, male, nutrition deficiencies in molybdenum, zinc, vitamin A. Signs and symptoms: dysphagia, which is difficulty swallowing in the most common symptoms. Initially with solids like meat, bread, and later liquids. Pain or burning in the middle of the chest, throat, or back. We have painful swallowing occurs as food hits the tumor. We have respiratory issue, chronic cough, hoarseness, and hemoptysis, coughing up blood. Systemic and other: weight loss, anorexia, vomiting, melena, which is black tarry stools, and hiccups, often with dysphagia. The hypercalcemia may develop due to bone metastasis or tumor production of parathyroid hormone related protein. The diagnostics: we have the esophageal gastroduodenoscopy, the gold standard for the diagnostics, allow for biopsy of tissue. The Byram solo, often the first test done, identifies irregularities in the esophageal wall surface. The endoscopic ultrasonography uses a probe to see how deeply the cancer affects the tissue and lymph nodes. CT scan and PET scan used to determine the spread metastasis to lymph nodes, lungs, liver, and other organs. Bronchoscopy views the trachea, bronchi to detect tumor invasion. For patient teaching, stop smoking 2 to 4 weeks before surgery to improve respiratory outcome. Oral care: perform oral care 4 times a day to prevent postoperative infection. Nutrition: enteral or parental support may need for up to 3 weeks post-surgery to allow incision to heal. Post-operative care, so for esophagotomy, respiratory, it's very important: coughing, deep breathing, intensive spirometry Turning every 2 hours and early ambulation are the highest priority to prevent respiratory complication. For diet, sit upright when eating, eat 6 to 8 small meals per day, drink fluid between meals, not with them, to prevent distension. Monitor for dumping syndrome, diarrhea 20 minutes to 2 hours after eating. Um, Use Imodium if needed. Pain medication teach the use of alternative pain technique and to request medication before painful activities. So now we go next. Esophageal trauma, the acute emergency. While less common, this is scary because of how quickly it can become fatal and the painful nature of the injuries. High mortality, the text notes that high morbidity rates are associated with esophageal perforation. Survival drops drastically if not treated immediately, with morbidity doubling just 24 hours after the injury. Violent causes, trauma can be caused by spontaneous rupture from vomiting, by Vami's syndromes, or by ingesting caustic substances like a drain cleaner, which cause severe chemical burns and dissolving of tissue. Critical complication, it can lead to shock, sepsis, and circulatory collapse very rapidly. Honorable we had earlier for honorable cancer, this is esophageal trauma. So the book expresses the most critical three: the cancer, the esophageal cancer, and esophageal trauma. The esophagus is the most common site of GI trauma due to its location in the thoracic cavity and proximity to the um, oropharynx. The most frequent causes are diagnostic and therapeutic endoscopic procedure. Other include indigestion of caustic agents, blunt injuries, and foreign bodies. Mort Mortality rates are high and time sensitive. Survival is 12 to 36% if treated within 24 hours. But mortality increases to 30 to 50 after 24 hours. Injuries are graded from 1 contusion, grade 5 tissue destrocation greater than 2 centimeters. We have the trauma can result from external force, I said, internal injury, foreign bodies, chemical burns, excessive force. This allows gastric contents to spill into the media stream, leading to media stenitis, septics, and shock. Signs and symptoms, we have pain, chest, back, or epigastric fever, dyspnea, and crepitus. Let's go to the next slide where we have the nice picture. So we have the factors we said already, the grading here, 1 to 5. The patho, like how is the rupture, it shows the nice pictures here. So the trauma can result from external force, right? The internal injury, the burns here, the rupture here, the Boev syndrome. It's the spontaneous rupture caused by sudden increase esophageal pressure from vomiting. We have the risk factors, endoscopic, diagnostic, and therapeutic intervention. Um, Behavioral, which is indigestion of caustic substances, drain cleaners, or foreign objects. Medical history, chronic alcohol use or chronic vomiting increases risk for spontaneous rupture. Trauma, motor vehicle accident, blunt injury or penetrating wounds, gunshot, stabbing. Signs and symptoms, we have the pain, chest, back or epigastric, fever, dyspnea and cryptus. From indigestion, severe pain in the mouth, chest, corrosive white crust in the mouth, excessive salivation, which is cyalorrhea, and gagging, perforation, dysphagia, vomiting, hematitis, hypotension, pallor, and signs of shock. Boy V syndrome, severe pain between shoulder blades or behind the sternum, hematitis, and circulatory collapse. For diagnostic, we have the chest X-ray, chest CT scan, contrast, esophagography are used to assess the extent and location of injury. The lab CBC, albumin, electrolytes to check for imbalance like hypokalemia from gastric fluid loss. Patient teaching. Infection control. Teach the patient to monitor for signs of infection such as fever, redness, tenderness, or increased drainage at the injury site. Medication, explain the importance of taking prescribed antibiotic and pain medication. Weight monitoring, encourage the patient to monitor their weights closely due to the risk of nutritional impairment. During discharge instruction, provide specific instruction on wound care and when to notify the healthcare provider. So that's it with esophageal trauma. Let's have a quick pop quiz and a little bit of summary. So the first round, what is it? What is the earliest clinical worrying signs of esophageal cancer? Answer: progressive dysphagia, difficulty swallowing. It usually indicates the tumor has already narrowed the esophagus by at least 50%. Question 2. In patients with GERD, what specific cellular chain signal a risk for adenocarcinoma? Answer is Barrett esophagus. This is when the normal squamous cells of the lower esophagus are replaced by columnar cells like stomach cells to resist acid. Question: how do you distinguish between leukoplakia and erythroplakia in the mouth? Answer is leukoplakia is the white patches that cannot be scraped off, often begin but 2 to 6% are early cancer. The erythroplakia, red, velvety patches, less common but much higher risk of malignancy. Last question for this round. What is the defining difference between type 1 and type 2 hernia? The answer is, for type 1, the sliding, the stomach slides up and down through the hiatus. Symptoms are mostly reflux like GERD. Type 2, the stomach rolls. So earlier it slides up and down. This is rolls up next to the esophagus. The risk is the volvulus, so the twisting, or strangulation, not reflux. The round 2, the diagnostic and labs. What is the gold standard test for diagnostic esophageal cancer? So the answer is esophagogastroduodoscopy. It allows direct visualization and biopsy of the tissue. Question: a patient arrives with a suspected esophageal perforation from trauma. What diagnostic test helps confirm this? Answer: a contrast esophagography or chest CT scan. Note that endoscopy is often risky if perforation is suspected. For a patient with severe stomatitis, the mouth sores, what labs value should you monitor for nutritional status? Answer is albumin levels. So the levels below 2.5 grams per deciliter indicate severe protein depletion due to inability to eat. So now we're in the round 3 for the NCLEX. Question: you are caring for a patient with a wired jaw, mandibular fixation. What is your absolute #1 bedside safety priority? It's a wire cutters. If the patient starts to vomit or choke, you must cut the wires immediately to prevent aspiration. Question: patient has just ingested a caustic chemical like drain cleaner. Why do you never induce vomiting? Vomiting brings the burning chemical back, damaging the esophagus a second time. You also avoid blind NG tube insertion to prevent perforating the weakened tissue. Question: a patient is recovering from a esophagectomy and starts having diarrhea and sweating 30 minutes after eating. What is happening and how do you fix it? Answer is, this is a dumping syndrome. The fix: teach them to eat 6 small meals a day, high in protein, fat, low in sugar, and do not drink fluids with meals. Question: How should a patient with GERD or hernia sleep to prevent nightmare reflux? Answer is with the head of bed elevated to 6 to 12 inches on their right side. Laying on the right side promotes gastric emptying. Last question. A patient with oral cancer has a radical neck distension. What is the priority assessment? Airway clearance, edema, swallowing in the neck can compress the trachea. You must listen for stridor, the noisy breathing, which indicates obstruction. So in the next slide, I will show you what I just read in case you want those questions for you to practice. Here is the pop quiz that we just answered, the question and answer. This is for round 1, round 2, round 3. So take a short screen in case you need it to practice, but we can practice more on the next part 3 about the NCLEX and how the psychology of answering questions related to this chapter. And I will see you there. Bye for now.
We finally made it!
Thank you again for your time and trust. I'm Mia, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.